This is the Mechanical Care Forum, episode 326 of Season 8, and I'm joined by Dr. Chris Showalter of MAPS, Maitland-Australian Physiotherapy Seminars. We talk about his professional journey, what he learned from Jeffrey Maitland, his description of that assessment method, and more this week on MCF. I'm Jason Ward, and this is the Mechanical Care Forum. Think of it as your weekly dose of inspiration, information, and entertainment, where we interview leading clinicians, instructors, researchers, authors, practice owners, and more, all for the purpose of sharing experience for improved patient care. This episode of the Mechanical Care Forum is free, and it's brought to you by myself and a small team to help you along your journey. If you'd like to show your support, you can do so by making a small donation or even a big fat one. We'll gladly take any amount, and we use it wisely to continue to produce this great content. Go to mechanicalcareforum.com to show your support. Hey everyone, and welcome back this week and to this season where we're seeking out other manual and physical therapy assessment and treatment approaches. So far this season, we've heard from John Childs with Evidence in Motion, Lisa DeStefano with the Michigan State University osteopathic approach, a re-airing of my interview with Brian Mulligan of Mulligan Concepts, Elaine Loneman of the St. Augustine's Manual Therapy Education Program, also referred to as the Paris approach. So I'm pleased to be able to connect with Dr. Chris Showalter with the Maitland approach today. That interview coming up in just a bit. Also, I'm glad to mention that I've got the opportunity to share an interview with Dr. Stanley Paris in the coming weeks, as well as John Kraus with Keompt, Kaltenborn Evian's manual therapy approach. So that's coming up later this season. Don't forget to sign up for my free weekly email update, which will keep you in the loop with each episode released. And it'll also keep you up to date on my other projects like Case Conversations and Inside the Science, and other opportunities, including discounts on my resources page and my affiliates and other. So sign up at mechanicalcareforum.com. For those of you out there who have spent time with an expert clinician, you know how beneficial that can be. If you haven't, you may not realize what you're missing. But in either case, it's not always convenient or feasible, especially in today's time, to schedule opportunities like this with a mentor. And this is one of the primary reasons we created Case Conversations several years ago, to tap into clinical expertise and experience from those who are further down their professional growth journey. So if you're out there all alone wishing you had exposure to some of the best, check out Case Conversations, especially now with guest experts like Robert Metcalf, Mark Miller, just in the next couple of months, and with topics like the challenging cervical patient, extremities, the thoracic spine, the fearful patient, carpal tunnel, headaches, and so many other relevant focuses month after month. It's a great time to join us. My free email subscribers have access to the first month for half off. And if you're in a therapy department or a practice with multiple like-minded clinicians, consider adding Case Conversations to your therapist's clinical development package. You can check it out at mechanicalcareforum.com. And don't forget, we're plugging right along week after week with my new podcast called Inside the Science. We provide summaries of practice-impacting studies and discuss them with the authors to help you keep up with the literature, which we all know we should be doing, but in reality, few of us adequately do. We've already highlighted case reports on the Sharp-Purser test and a follow-up systematic review with Cody Mansfield. We've also discussed the cost impact of quality-assured mechanical assessment and a prospective study of centralization of lumbar and referred pain, a predictor of symptomatic discs and annular competence with Ron Donaldson. The landmark study Doesn't Matter Which Exercise, as well as her case series with Audrey Long. But we're just getting started. Byron Schneider joined us to discuss the validity of physical maneuvers for SI joint pain, and most recently we've looked at pain and functional outcomes associated with injection response and those physical exam maneuvers from SI joint injection. We'll be looking at the shoulder orthopedic tests, cervicogenic headaches, neck pain originating from cervical disc with Nikolai Bogduk, a well-known epidural steroid injection effect study by Hans von Helvert, as well as a look at the Toledo classification system. So if you want to begin keeping up with the relevant musculoskeletal research better than you ever have before, check out Inside the Science and consider subscribing as a premium subscriber to receive the full discussion, a PDF of the study, an infographic to use for patient education, marketing, and referral source education as well. Check out Inside the Science at mechanicalcareforum.com. Okay, we'll move on with our guest expert today. Here's part one with Dr. Chris Showalter. Enjoy. So with me today on the Mechanical Care Forum, I'm pleased to invite Mr. Chris Showalter. Chris, thanks so much for taking time out of your schedule and joining us on the podcast.
Oh, it's excellent to join you, Jason. Looking forward to talking to you and talking to your listeners.
Fantastic. Chris, so just in case those that may not know you want to understand from an elevator speech perspective, where are you, Chris, and what do you do?
My name is Chris Showalter. I live in eastern Long Island in New York, about 2 hours from New York City. I'm a physical therapist. I hold a DPT. I've been an OCS and a fellow at the American Academy of Orthopedic Manual Physical Therapists, FAOMT, for a little over 20 years. My clinical background is primarily Maitland. I do have some very good exposure to Mackenzie and myself. I spent a couple of weeks in New Zealand in the summer of '87 with Robin in New Zealand. But my primary emphasis is Maitland. I had the opportunity to study directly under Jeff Maitland in Australia. So I'm a dual national, US and Australia, but the funny accent comes from 20 years in Australia. And then the other thing is I'm the chair of the Accreditation Council on Orthopedic Manual Physical Therapy Education. So that's the group that sets the standards and grants accreditation to programs that meet our standards, which also meet AOMT, the American Academy of Orthopedic Manual Physical Therapy, and those graduates from those programs are conferred with the title FAOMT, Fellow of the Academy.
Mm-hmm. Fantastic. Chris, thanks for giving us a little snapshot of what all you're involved in. We'll get into a lot more of those things, of course, which is the reason that I wanted to have you on, your experience with Jeffrey Maitland and your focus on that, but also the other involvement. So before we do that, we always appreciate kind of getting a perspective of what led you to where you are. Can you talk a little bit about your professional development, where you started, those initial interactions with patients, perhaps, that kind of were either frustrating to you or made you want to learn more, and which has kind of directed you to studying in the direction that you have?
Sure. My college education started in science, doing reproductive physiology and anatomy. That turned into an honors degree, and I actually started a PhD in reproductive physiology in sheep. And I realized that the department was not the place for me. I don't like being constrained by departmental rules. I'm more of a free-form private practice entrepreneur kind of guy. So I had three options at that point: go into veterinary school, go into medical school, or go into PT school. I chose PT school primarily because I was a rugby player, had a couple of injuries, had them well worked out by good PTs, and realized, it's a pretty decent career, lots of flexibility. My first professional degree was Bachelor of Applied Science in Australia in 1987 in Melbourne. And then I went and worked in a private practice with a mentor of mine named Chris Conway in a town called Ballarat in central Victoria in the south of Australia. And he was Jeff Maitland trained, and he put my feet firmly on the path. I then went to South Australia and worked directly under Jeff. And then at the end of that, I came to the United States and I met another great mentor, a gentleman named Bob Sprague, who founded what is now MAPS, Maitland-Australian Physiotherapy Seminars, in 1985. Each of those individuals has had an enormous impact on my life. Jeff, Chris Conway, and Bob Sprague. What was astounding to me about all of them was their humility. They were clearly at the top of their game. They used exquisite clinical reasoning, but they weren't full of themselves. They weren't overly, they weren't prima donnas. Mm-hmm. One of the things that you and your listeners have probably noted is that when you have a skilled manual therapist with their hands on you, no matter what their brand of manual therapy, the suppleness and the softness of their hands imbues in the patient a sense of comfort, mm-hmm. because you realize this person is a pro. This person has great hands, and you can feel it when they touch your neck or your wrist or your shoulder, whatever. Is that what you were looking for, Jace?
Absolutely, yeah. And I, again, I want to dive deeper because we understand that Jeffrey Maitland has, developed a particular algorithm of assessment and treatment, and those that have learned from him have kind of progressed it. We want to understand more about that. And so you're already kind of hinting towards some of those discussions. Talk to us a bit about your time with Maitland first before we get into the MAPS and the continued development of that assessment approach. What do you recall about his, perhaps it's illustrated through a patient experience or you just observing him treat? What was it about him that resonated with you and has influenced you to the degree that you would devote much of your work toward that direction?
The first thing that comes to mind as you ask me that question is humility.
Yeah.
Jeff was an incredibly humble and private man. He never liked to call it the Maitland approach or the Maitland concept. And in fact, when I purchased MAPS from Bob Sprague, I went to Jeff and I said, and at the time it was called CPEA, Cayuga Professional Education Associates. which as a branding model didn't say much about what was being taught. It was named after Lake Cayuga, which is in upstate New York, which is where Bob lived. And so he sort of picked a geographic landmark. Mm-hmm. So I went to Jeff and I said, listen, because at that time, we're talking the early 90s, everyone had to go out and get their brand name techniques. They had to get their Paris technique and their Mulligan technique and their McKenzie technique and the McConnell technique, right? And there was no Maitland technique. And Maitland's not a technique. Maitland's a philosophy of patient-centric assessment. We'll talk more about that in a minute. But So I went to Jeff and I said, I want to call this company the Maitland approach. He said, absolutely not. And I said, why? And he said, because that means it's all about me. And he said, it's not all about me. It's about the other Australians who were involved in not only the early years and the synthesis of it, but the fruition and growth of this approach. Mm-hmm. So he said, I'll meet you in the middle. If you call it Maitland-Australian Physiotherapy Seminars, I'll back that. I said, okay, that's fine with me. Because if you look back in Australian manual therapy, if you look at people like Bob Elvey, who invented the brachial plexus tension tests, which became the ULMTs, okay? Jenny McConnell, who I mentioned before, Darren Rivette, Mark Jones, David Butler, Mary McGarry, Ruth Grant, Gwendolyn Jull, Carolyn Rethcharge. All of these people have one thing in common. They all trained with Jeff Maitland. They all have the core clinical reasoning process. So what impressed me about Jeff was his humility and his absolute attention to detail with a religious zeal. You didn't just gloss over stuff. If you found something that was clinically meaningful in a patient, you explored it to its nth degree to get as much information as you could about that patient.
In terms of the clinical delivery of his assessment and his treatment, what else? The humility, obviously, you're speaking of his character, and that has to be there or should be there to begin with, of course, which provides a way for his skills and what he delivered. But what do you remember about the delivery of what he gave to his patients?
So assessment was key, and assessment is key in Maitland. Jeff used to say at the end of your subjective examination, and remember, the subjective examination is not filling out forms for the electronic medical record or reporting to a third-party payer, because generally that they're broken down. They're interested in range of motion. That's their main thing. What's the range of motion and a couple of other characteristics to see how this patient's doing, okay? Clinical assessment to Jeff was everything. And Jeff used to say at the end of your subjective examination, you should be 85% sure where to put your examining finger. That's how important the subjective is in the Maitland approach.
Mm-hmm. Yeah.
In terms of his interaction with patients, he was always fair. He was always unbiased. He was always free to recognize new phenomena. He was easy. He could recognize new phenomena like Mulligan's lady who couldn't move her finger. He could recognize new phenomena like Mackenzie's Mr. Smith, who was lying in prone extension on the table, right? He was open to recognizing that. There's a video of Jeff from the 80s where he talks about what disturbs him about people is people sometimes, clinicians, sometimes have what he calls a tin can approach, meaning a tin can, like a Campbell's soup can. Mm-hmm. And that is that their clinical direction to seek information is limited by the fact that their assessment process and their thought processes are trapped within a metal can, trapped at the bottom, trapped at the top, and trapped all around, and not having the flexibility to think, we would say these days, think outside the box, look at things in a different way, right? Jeff used to say the subjective examination is an interrogation with empathy. Jeff's number one, and we teach this in MAPS, Jeff's number one principle in the management of patients is to have an empathetic understanding of what the patient is enduring and how this condition is affecting their life. Now that's super patient-centric right there. That's number one. It wasn't find this or treat that. It's all about the patient.
Mm-hmm. So if you meet someone and they ask you, what is MAPS? How do you describe it?
It's patient-centric, exquisitely detailed assessment. Its assessment goes down a continuum from the subjective examination to the active physiological examination, the passive physiological examination, and the passive accessory examination. We're looking to find something called the comparable sign. And that is the exact movement that either increases the pain of a stiff dominant syndrome or decreases the pain of a pain dominant syndrome. We then immediately sit the patient back up and look at the other parameters. So if there was a limitation in right rotation and we treated them with a unilateral PA on the left or right, the unilateral postero-anterior mobilization on the left or the right, we would sit them back up, and we're looking for two things. We're looking for a change in their subjective report of symptoms and a change in an objective measure of changes in movement. And we do that on every single intervention. I got a baseline subjective and a baseline objective. I do my intervention, whichever it is, and now I've got a post-treatment, immediately post-intervention, subjective and objective. A lot to unpack there, Jason.
No, it's good. I appreciate that. There's a lot of similarities. You know, those of us who haven't had as much background or haven't had training in Maitland or in MAPS, here's some commonalities and some similarities with how we test, intervene, and retest. How do you understand? You spent time with Robin. You've spent time with others, it sounds like.
Yeah.
How does it differentiate, or how would you differentiate it? What's its uniqueness from other approaches?
I think the uniqueness of Maitland, and I'll compare it directly to Mackenzie, okay? Both of which I have experience in. And I took Mackenzie A through C in Australia in the late 80s. I honestly haven't taken a Mackenzie course since. I'm mostly teaching, not having time to go get, right?
I understand.
So
yeah.
that's just the nature of the profession. But Jeff's perception, and I talked about the tin can kind of thinking, Jeff's perception was that each individual PT needs to evaluate patients and develop their own clinical patterns or clinical pattern recognition such that they build a library in their head, such that when they see a patient with similar conditions, they can draw on the assessment and treatment that they used in the patient with a similar condition in the past. He didn't like biomechanical discussions, and he didn't like, and this is probably going to anger some of your listeners, but I apologize. The truth is the truth. He didn't like trying to subgroup people too far. He felt that, and I think the research at the moment shows us that there are challenges with subgrouping. I'm not talking about Mackenzie subgrouping. I'm talking about things like low back pain subgrouping. You know, it's the holy grail of research is to find a true subgrouping that works for everyone. Yeah. And thus far, we're not there. But Jeff felt that it was more important, and I agree with him, and I continue, and MAPS teaches in this way, rather than telling you what you should do when you see the condition X, I'd rather give you the tools to develop and learn such that when you have that aha moment, I did this intervention and this was the result, that was appropriate for that patient. I'm putting that in a box in my head called patient with acute lumbar radiculopathy on the left. And the next time I see that, I'm going to go back to that information and I'm going to learn as a clinician through metacognition rather than follow a set of rules.
So is there a balance, however, with having, for a determined staph infection, we understand what the treatment is medically.
Sure.
And so whether that's in the knee or the earlobe or the wherever, it doesn't matter. If when we diagnose that accurately, then we know the treatment. Is there value in having a fairly defined treatment that is effective based on some type of symptomatic or mechanical or concordant sign response, rather than having it, what I'm perceiving you're saying is, let the clinician identify and be creative, perhaps, in treating the way they want? Maybe that's a misunderstanding.
So we've unpacked a lot of stuff here. This is going to be a 7-hour podcast. We can break it up over a couple of months.
There you go.
So first and foremost, I have no problems with giving younger clinicians rules to live by, rules of thumb, ideas, things that work, okay? You know, if you look into the research in terms of the clinical reasoning and the types of clinical reasoning, as you probably know, there is system 1 and system 2 style reasoning, right? And, you know, system 2 is the reasoning that we're trying to get to with Maitland. For the newer clinician, the new graduate, let's say, okay, first professional degree, they're going to use a system 2 style clinical reasoning, which is hypothetico-deductive, okay? And that's going to require vertical thinking. And it's often the kind of thinking that's used by novices.
Mm-hmm.
And that's great because they have to have somewhere to start from, right? Because they don't have the clinical experience. It tends to be kind of slow. It's very analytical. It's very conscious. And it's very conceptual. Now, in comparison, System 1 thinking, which is described as experience or heuristic or gestalt, is more of a top-down approach.
Mm-hmm.
It's inductive and it uses lateral thinking. It's often used by experts. And it can be rapid and intuitive. It's often unconscious and it's very contextual. So when you have worked with, Jason, when you and your listeners have worked with a really skilled practitioner,
mm-hmm.
no matter what their brand, no matter what their religion of manual therapy is, right?
Mm-hmm.
You sit back and you scratch your head and you say, how did you get from there to there? And the answer is, unfortunately for the younger listeners, it's experience.
Mm-hmm.
You have to have experience. You have to use clinical reasoning. You have to use metacognition, thinking about the way you think, critically analyzing your skills and how you're applying them. And you have to learn in that fashion. So I have no problems with, sort of guidelines, like the different characteristics in the McKenzie approach.
Mm-hmm.
I have no problems with them whatsoever, as long as people can understand that it's a subgrouping, not a law, because there are patients who show characteristics, as you and I know, that cross over subgroups, right?
Sure.
So then the question becomes, which one do you treat? All right, the displacement or the dysfunction, right?
Mm-hmm.
So I would describe the different, I sort of alluded to this, the different styles of manual therapy are kind of like different religions.
Mm-hmm.
And I don't want to insult anyone here. Full disclosure, I'm a Roman Catholic, so I know all about dogma. I know all about guilt, right?
Sure.
But let's compare Christianity with Judaism and Islam, okay?
Okay.
They all have Abraham, all right? The story of Abraham is in all three books.
Mm-hmm.
Now, the Muslims call him Ibrahim, but it's the same person. It's the same story, okay? What we can all agree on is that, hopefully, is that there's, and I'm 58, so I'm really hoping there is a God because I'm going to be meeting him in a shorter time than the 20-year-olds on this podcast.
Right.
We all hope that there's a kindly God up there who will look favorably upon us, right?
Mm-hmm.
So the different religions of Mulligan, McKenzie, Paris, Maitland all have different ways in which they get to the final answer. But the final answer for skilled clinicians is using clinical reasoning based upon the presenting signs and symptoms, also drawing on your experience with prior patients, and as necessary, grabbing those things that work from the more predictive, more subgrouping style.
Mm-hmm.
In Maitland, we have a concept, Jeff had a concept which is very valuable, called the semipermeable brick wall. And on the left-hand side of the wall, we have anatomy, physiology, pathology, kinesiotherapy, kinematic studies, biomechanical observations, and biomechanical theories that come from them. That's the left-hand side of the wall. That's the theory side of the wall. That's what we think we know about this individual patient. On the right-hand side of the wall is the clinical side of the wall. It's that individual patient, their clinical presentation, their unique history, their signs and symptoms, and the clinician using a methodology of hypothesis generation, testing, either to throw out a hypothesis or throw in a new hypothesis or modify an existing hypothesis as information comes together in the subjective and the physical exam. So Maitland therapists tend to spend most of their time on the right-hand side of the wall with the patient observation side of things. We all have our degrees that allow us, when you get your license to practice, it's a license to practice, right?
That's right.
And with practice, hopefully you'll get better.
Yeah.
We all have our perspectives that we got in school, and they're all biased by what we were taught in school. We can go to the left-hand side of the wall and we can take useful information from there. Anatomy, physiology, pathophysiology, biomechanics if it works. Okay. If it doesn't work, if the patient doesn't, so for example, Chad Cook and I did some studies back in the early 2000s on coupled motions in the spine. Okay. So coupled motion is inconsistent in the lumbar spine and is not predictive. These are studies you can look up, Cook and Showalter.
Mm-hmm.
Coupled motions in the thoracic spine are inconsistent. Coupled motions in the cervical spine are consistent. In the lower cervical spine, they couple to the same side. But in the lumbar and thoracic and upper cervical, all bets are off. Someone might be someone might be a same side coupler, someone might be an opposite side coupler in the same patient population. So we can go grab that information if it helps us clinically manage the patient. What we can't do is we can't force the patient into someone's theory. Yeah. And evidence-based practice is three equally weighted interplaying mechanisms, right? Best available evidence, clinical experience, patient values. So anytime that we take a patient, we force them to fit into into anyone's paradigm, we are potentially doing a disservice to the patient.
And gosh, you're right. 7 hours might have just gone to 8 or 9 hours, but that's okay. We'll do what we can.
We'll be here all week. Tip
That's
your waiter.
Right. Chris, talk to us about what you initially understood and began teaching MAPS as, and how it's evolved and changed. Any system that's worth its weight, perhaps, is going to develop and evolve because more additional or more accurate truths are discovered as we continue to learn. Can you talk about the comparisons of it over time?
Yeah, well, I mean, I'm changing every day. I get better every time I see a patient. I get smarter, I think. My teenage kids may not agree with that, but I do get smarter every day. When I first started teaching with MAPS, which was in the early 90s when it was CPEA, it was pretty rudimentary. I mean, we had 2 courses. The spinal course, the manual for the spinal course had 9 photographs in it. Everything else was descriptive, okay? We flew around the country with circular slide carousels. You remember those, Jason?
I
You're
do.
maybe even too young to
No,
remember.
I remember.
A lot of your listeners may not remember. And a slide would get jammed and you'd be screaming at the AV guy in the back of the room, pull a slide, because it'd actually burn and melt on you.
Right.
And getting a slide made up was like pulling teeth. You know? That wasn't PowerPoint, you know? Yeah, so I would say in terms of what I see my role in the universe as promoting the Maitland approach now that Jeff and Bob Sprague and others have gone. That's my responsibility. So we've done a fair amount of research. You know, our research group has done a fair amount of research into particularly the comparable sign. Now, I heard you call it the concordant sign, and that's fine, and it doesn't rankle me. I will point out that Maitland first characterized the comparable sign in 1981. He finally got it together if you read Maitland's papers and books, it was a concept that was moving through his head, but he never really characterized it and defined it. So in 81, he defined it. Concordant came out in the early 2000s.
Okay.
So I'm 58. I'm going to go with the history. I'm going to say that it's originally comparable. There's some subtle differences between the two, but it's about finding that movement that is most representative of the disorder that the patient has, right?
Chris, do you mind contrasting? Give us the difference of comparable sign versus concordant sign.
Well, I can speak very intelligently to the comparable sign, obviously, which is that movement that either increases or decreases or changes in some way that patient's exact symptoms.
Okay.
All right. Now, the concordant sign, as I understand it, and it seems to have evolved a little bit over time, and Duke graduates like to use it because Chad Cook likes to use it, and Mark Laslett wrote about it early on in the 2000s. So the concordant sign, I think, requires more of the patient to determine which movement is causing it. And the comparable sign requires the patient and the therapist as a working team to determine which one is the most important.
Yeah, fair enough.
The thing with either of the signs is that, you know, symptom provocation is far superior to palpation for movement. We know that. Your listeners know that. We don't have to talk about that research, but that's well locked in. But you cannot deny symptom provocation with a movement, right?
Yeah, excellent. So any approach has, misunderstandings from those outside of its camp. And
Sure.
So I might, tease and say, how are your thumbs, Chris, from all that pushing, since that's all Maitland clinicians do, right, is mobilize with their thumbs. Obviously, that's incorrect. But what are those common misconceptions and misunderstandings by critics of the system?
Yeah, brother, I just threw a digital rotten tomato at you and lettuce like they would on Broadway in the 30s and 40s, right?
Right.
Yeah, my thumbs are fine. I know people who have thumb problems. I am religious about keeping my thumbs back to back together when I'm actually mobilizing into resistance.
Yeah.
My thumbs are supple and soft. And no, seriously. When I'm looking in at early resistance, what we call R1, first onset of resistance, in around R1, it's just my thumb tips doing the work. They're well innervated with nerves. They're well connected to my sensory homunculus. And so I'm looking for the subtleties of movement with thumb tips. When it comes time to move the cervical spine on a 320-pound lineman from the Bears, I'm not using my thumb tips, okay? Mm-hmm. I've got my thumbs back to back, buttressed together. My hands are actually pushing my thumbs together to keep them back to back to prevent any extension or hyperextension. But it's about protecting yourself, you know? Yeah. So, my thumbs are fine. Other misconceptions with joint jigglers. We just want to treat joints. We just want to jiggle and push joints. Misconception, joint mobilization, right? Now, we know, you know, I know, your listeners know, the effect of mobilization and manipulation is not just mechanical. Mm-hmm. It's mechanical. There's a potent neurophysiological effect. There's significant anti-inflammatory effects. The research tells us this. We can decrease fibroblast production and reduce the inflammation with mobilization, okay? Mm-hmm. And there's a substantial psychological effect for patients of the hands-on. So, I would say this about, could we describe it as joint mobilization? I'm moving the C3-4 joint. I'm on the posterior articular pillar of C3 doing a passive accessory movement, and I'm affecting this area somehow. Now, a prescriptive biomechanical approach might say to me, Chris, when the patient has, I'm just making this up, when the patient has a limitation in left side bend and you find the lesion at C3-4, you must mobilize C4, not C3, but C4. And I'm going to say, well, this is a really big guy with a really big neck. I can't really be sure that I'm on C3, C3-4 joint line, or C4. And if I can't find it, and I've got 33 years experience, what happens to the new graduate who doesn't have that amount of experience with necks? How can they find it? So the Maitland therapists kind of sit back in yoga position and make circles with both fingers and thumbs and go, reproduce the comparable sign. Whatever movement, whatever it is, whatever direction it is that reproduces their symptoms. So to go a little bit further into that, let's say I'm going to mobilize C3. And it's a pure unilateral PA, postero-anterior. Okay, so that might get some of their comparable sign. How do I get their exact comparable sign? Well, I might have to angle that unilateral PA, not pure PA, but PA medial 15 degrees. Mm-hmm. And at the same time, superior 10 degrees or inferior 12 degrees. It's kind of hard to follow on a podcast, I know, without a drawing on the blackboard behind you. But just understand that our perception is to try and find the most comparable movement with the least amount of force that reproduces their symptoms. Mm-hmm. Maybe a better way to explain that is this. Let's imagine a patient with a shoulder problem, okay? They have limitations in forward flexion. Mm-hmm. It's limited. It's got limited range. It's uncomfortable. Is that your pain? No, that's discomfort. That's not my sharp biting pain. Okay, so that's flexion is a joint sign. It's abnormal. It's aberrant. We want to see it fixed in the long run, but it's not the one reproducing the symptoms. Mm-hmm. Well, what about abduction? Yeah, I get a painful arc around 120. Again, it's stiff and tight and it aches, but it's not the sharp biting pain. I get up there deep inside that joint. Mm-hmm. We might have to examine that shoulder in some weird sort of flexion, abduction, internal rotation or external rotation, and horizontal flexion to get the exact point where we reproduce their symptoms. And so that journey of finding where the exact symptoms are results in you treating at that point the exact symptoms of that patient. Mm-hmm. And then you go back and look at the joint signs like the shoulder flexion, shoulder abduction, and they tend to get better.
Mm-hmm. But it's all determined on the patient response or Correct. Some combination of patient and, mechanical or some form of other response.
Yeah, it's all patient response. It's very strongly patient response. But because we're physical therapists, not massage therapists, we understand, and no offense against massage therapists, they do great work, but they don't have the background pathophysiology, anatomy, physiology, biomechanics, kinetics, etc., to make an informed decision about how to do that.
And there you go with episode 326. Grateful to Chris for his insights and for his interest in pushing us all along to become better clinicians and manual therapists. Be sure to come back next week for part 2 and the remainder of my conversation with Dr. Showalter at mechanicalcareforum.com. While you're there on my website, check out our new podcast, Inside the Science, providing audio summaries of relevant studies which will impact your clinical reasoning and improve your knowledge of the literature. And don't miss the coming months of Case Conversations, audio patient case discussions with some of the best clinicians using actual patient cases to explain how they clinically reason through these cases, which is serving as a virtual mentoring resource for many clinicians who are a bit isolated. You'll find it at mechanicalcareforum.com. All right, I wish you a great week with your patients this week. And join me right back here next week for more of Sharing Experience for Improved Patient Care. The views and opinions expressed on this podcast are those of the founder and host, Jason Ward, and his guests, and may not be those of the McKinsey Institute International. The content here is independent of the McKinsey Institute International and is not associated with its educational program.